starting our topic on gastric sarcoidosis. Gastric sarcoidosis. As a term, sarcoidosis means first one, granulomatous condition. It is a granulomatous lesion. It's a systemic disease affecting almost all parts of your body, starting from your head to toes. So sarcoidosis is most common site for sarcoidosis. Some of few points according to MCQ will discuss. Most common site in general is your lungs. GIT. So what is the incidence of sarcoidosis in GIT? It is very rare. Almost it is only 10% of sarcoids are seen in GIT. So in GIT, what is the most common site is which is your stomach. In GIT, most common site is your stomach. So how does it present? So gastric sarcoidosis presents with some of the clinical features that are non-specific or prodromal. That includes epigastric pain, nausea, vomiting, weight loss. Okay, so these are non-specific. The symptoms which I want you to remember in your mind is that it is a pernicious anemia and achlorhydria. So I will tell why these two symptoms is very important for you to remember in the upcoming slides. So once you have your symptoms which is non-specific, you have to arrive at a diagnosis. So the next step in your management or proceedings is to do an endoscopy. So in endoscopic there are two features. One is you must support your diagnosis. The other thing, you have to confirm the diagnosis. For confirming, you have to do a biopsy. For supporting, you do your UJ findings, macroscopic findings, in which you find there is multiple pre-pyloric erosions with some regions of normal mucosa may be also present. That is due to microscopic granuloma, and so there is a distal part of the stomach gets narrowed, which leads to pyloric outlet obstruction or your gastric outlet obstruction. So the rare causes for your GU is sarcoidosis, one of the rarest. So moving on to microscopic features. So microscopy or biopsy, what you're going to see is your non-caseating granuloma. So once you're seeing non-caseating granuloma, especially in a setting like India, so you have to rule out tuberculosis, which every clinician or the surgeon sees in the OPD every day. So the other differential diagnosis would be Crohn's. So you have to rule out these two other granulomatous lesions, which is also a chronic condition and also non-specific symptom. So moving on to treatment. So like any other sarcoid, here also first line of management would be steroids. That is glucocorticoids. So if it fails, then we move on to subtotal gastrectomy. Right, so this is a brief outline about the gastric sarcoidosis. So in the next few minutes I'll be speaking or showing you the images of gastric sarcoids and some other differential diagnosis that you must know while studying this. So first focus on the first picture, which shows you the normal Drew gaze or the normal UJ finding, which is with your normal Now move on to the fourth picture, which shows you enlarged, multiple enlarged rugies, enlarged gastric glands, enlarged gastric glands. So we give a term gastropathy. So these glands are also called as mucous glands and have a special type of a name called as foveolar glands, which you find in your pathology in HP. So why this mucous glands or the gastric glands enlarge is due to the fact that the important role of transforming growth factor alpha, there is increased amount of TGF alpha and it is not beta, which is a most common error or wrong every student do it. So remember, it's TGF alpha which leads to increase mucus secretion and mucus gland hyperplasia or hypertrophy, which in loss leads to protein loss. So one side there is increased gastric glands or mucous glands, on the other side it is parietal cell atrophy. So as you all know, the parietal cell is the reason for its cell secretion. So when there is no parietal cells, it leads to achlorhydria. So one side there is a protein loss and there is a hypertrophy or hyperplasia of the foveolar glands or the mucous glands of the gastropathy, and we name this as a protein losing gastropathy with achlorhydria and parietal cell atrophy with increased expression of TGF alpha. The name given for the disease is Menetriers disease. So there's lots of MCQ points in this, and a final point I want to stress upon is that this Menetriers disease has an increased risk for adenocarcinoma. So the treatment that differs from sarcoidosis here is you have to definitely do gastrectomy. We can't try with your steroids or some other therapies. And another feature where I stressed upon is that the achlorhydria and pernicious anemia, because this is an important differential diagnosis you must do for your Menetriers disease, to rule out your Menetriers disease. So what does the second and the third picture signifies here is that why I put up this picture is that in the coming slide you will understand it. This is the ugescopy findings of a gastric sarcoid, which there is hypertrophy or increased mucous glands with normal pale mucosa. That is due to your anemia. And what you see in this picture, the CT findings, that lymphadenopathy. As you all know that sarcoidosis has a great tendency for lymph node spread, and whichever region it affects, you tend to get lymphadenopathy. I want you to again understand two other syndromes or two other entities are associated to other entities associated with sarcoidosis. When it involves lung, both the hilar lymph nodes get enlarged, and this both bilateral hilar lymphadenopathy with your salivary gland lymphadenopathy gives rise to some signs which are called as the panda sign or lambda sign or kappa sign, and the disease you come across is called as heat foods disease, which I show you here. So heat foods disease is nothing but involving your uveo parotid fever, that is nothing but your eyes and the salivary glands are involved. So uveitis, parotid, and lacrimal submental swelling, and there is this facial palsy. Important to note here, this is unilateral facial palsy is there. So these salivary gland lymphadenopathy gives a sign called as panda sign, And bilateral hilar lymphadenopathy gives rise to lambda sign and kappa sign. And important that in fact we get these findings in gallium scan. Okay, so another important point you must remember in this Headphones syndrome is that biopsy is must before you're starting your empirical therapy. Okay, that is why biopsy from your lacrimal gland is must. Whereas a similar entity is called as a Lofgren syndrome. Lofgren syndrome is a prodromal phase of a disease, and it has non-specific symptoms except 2 points you must remember. One is arthritis, another is erythema nodosum. It's a picture-based question many times asked previously. This erythema nodosum is a feature of sarcoidosis or Lofgren syndrome, which is exclusively common in females. So females have erythema nodosum and the males as arthritis. The good thing about the disease is that it is self-limiting and no need of any steroids. 90% of the disease is self-limiting and no need of a biopsy. So these things you must remember when you talk about sarcoidosis. Thank you.